Hello everyone, in this video we are going to be discussing about the pharmacology of the cough. But first thing first, what is cough? It's a useful physiological mechanism that serves to clear the respiratory passages of the foreign material and excess secretions. The cough reflex is complex. It involves the central and peripheral nervous system as well as the smooth muscles of the bronchial tree. Now let's discuss about the mechanism of the cough. Stimulation of mechanoreceptors and chemoreceptors sends the afferent impulses to the cough center that is present in medulla. This sends the efferent impulses via the parasympathetic and the motor nerves to the diaphragm, intercostal muscles, and in the lungs. Then this causes the increased contraction of the diaphragmatic, abdominal, and intercostal that are the rib muscles. And this causes the noisy expiration that is referred to as cough. Now let's discuss about the types of cough. So as you know, there are two types of cough, the dry cough and the productive cough. So now let's discuss them one by one. In case of dry cough, this dry cough means that there is no sputum production in this type of cough, while in the productive cough there is a sputum production. Now the causes of the dry cough and what are the conditions in which both of these cough can be present. So the causes of the dry cough can include the environmental allergen and can be present in the asthma or the upper respiratory tract infections like sore throat, tonsillitis, etc. Then the drugs like the ACE inhibitors, beta blockers and aspirin can also induce the dry cough. Then the causes of the productive cough can include the flu, TB, COPD, pneumonia, bronchiectasis, lung abscess. Now as a dry cough is simply an irritation, it is not productive, so this should be suppressed. While productive cough shouldn't be suppressed as it is protective in nature, because we want the mucus to be removed. Now let's discuss about the pharmacology of the cough. So we're going to discuss the drugs that are present in the class of the dry cough and the productive cough. So there are two classes of the drugs that are given in case of dry cough. These are the antitussives and the mucoregulatory agents. Now in the mucoregulatory agents, there are anti-inflammatory agents and the anticholinergic agents. In case of the anti-inflammatory agents, corticosteroids and the indomethacin, they can be given. And in the anticholinergics, we have ipratropium and atropine. Now let's discuss about the antitussives. In this we have the drugs that are belonging to three different categories. Some act centrally, some peripherally, and some can act both centrally and peripherally. Now in centrally acting we have opioids, non-opioids and antihistamines. Then opioids we have codeine and fluocodeine. The codeines are semisynthetic opioid and analgesics, and these are potent cough suppressants and they can cause drowsiness. They have mild analgesic actions and they are weakly addictive as opposed to morphine. And as they can trigger the asthmatic patients, that is why it shouldn't be used in the asthmatic patients. Now we have fluocodeine, and fluocodeine is structurally related to codeine. It's more potent and long-acting and it is better tolerated as opposed to codeine. Then it causes less drowsiness as compared to the codeine. Now let's discuss about the non-opioid class of drugs. So in this category we have dextromethorphan and noscapine. Now dextromethorphans are less addictive and they are not analgesic and they cause minimal drowsiness. Then noscapine are naturally occurring alkaloids and they are very potent opium alkaloids. These are also not analgesic and they do not cause drowsiness as well. Then they are popular cough suppressants and they also shouldn't be used in asthmatic patients. Then antihistamines cause sedation and they are anti-allergic, as you already know. Then here we have the different drugs like promethazine, chlorpheniramine and diphenhydramine. Now let's discuss about the drugs that act peripherally. So in this category we have the two types of drugs. One that acts above the larynx, these are also known as demulcents, and the other acts below the larynx. Now let's discuss about the demulcents. So in this category we first have the lozenges. Now, these are basically the small medicated tablets. They dissolve slowly in mouth to temporarily stop the cough, lubricate, and soothe the irritated tissues of the throat. Then syrup or honey or the licorice, they can also be present in this category. Then steam inhalation or the nebulization can be given below the larynx. So in the steam inhalation, we have the tincture of benzoin or the menthol. Then in the nebulizers, we have the benzocaine or the lignocaine. Now the drugs that can act both centrally and peripherally. So in this category, we have the carbetapentane and the benzonatate. And benzonates are mild local anesthetics. Now let's discuss about the drugs that are present in the category of the productive cough. So here we have the adjuvant and the mucoactive or the mucokinetic agents. In adjuvant therapy, we have the bronchodilators, for example, the salbutamol and terbutaline. Now in mucokinetics, we have expectorants or the secretion enhancers and mucolytics. Then we will also discuss about the pharyngeal demulcents. Now examples of the expectorants are the hyperosmolar saline, sodium potassium citrate, sodium potassium iodide, ammonium chloride, or the guaiacolate or the guaifenesin. Then in mucolytics, we will discuss about the ambroxol, bromohexane, and acetylcysteine, carbocysteine. Now, ambroxols are basically the metabolite of bromohexanes, and they also have the same mechanism of action as that of the bromohexane. But they are more useful in the mucus plug. Then we have the bromohexane. Their mechanism of action is that they cause thinning and the fragmentation of the mucopolysaccharide fibers, and they also increase the volume and decrease the viscosity of the sputum. Now the acetylcysteine, so it decreases the viscosity by splitting the disulfide bonds of the mucoprotein. Then it works at the pH 7 to 9. Then we have carbocysteine, and it cannot act by splitting the disulfide bonds, and it shouldn't be used in the asthmatic patients or in the patients with the peptic ulcers. Then lacrimation and rhinorrhea are the side effects of bromohexane. Now pharyngeal demulcents that act above the larynx, so they increase libation and cause the soothing effect. Then in this category we have syrup, lozenges and lintex. Now let's have a recap. So in the dry cough we have the mucoregulatory agents and the antitussives. Then in the mucoregulatory agents, we have anti-inflammatory agents and the anticholinergics. Then in antitussives, we have the centrally, peripherally, and the both acting agents. Then centrally, we have the opioid, non-opioid, and antihistamines. Then peripherally, we have the drugs that act above the larynx and below the larynx. Then in the productive cough, we have the mucokinetic agents and adjuvant therapy. In the mucokinetic agents, we have expectorants or the secretion enhancers, pharyngeal demulcents, and mucolytics. Now let's write the examples. So corticosteroid, indomethacin, atropine, ipratropium, codeine, fluocodeine, noscapine, dextromethorphan. We have the phenyramine, diphenhydramine, promethazine, lozenges, syrup, licorice, steam, nebulizers. Then the sodium potassium citrate, sodium potassium iodide, hyperosmolar saline, ammonium chloride, guaiacolate, and guaifenesin. Then lozenges, syrup, glycerine, licorice, bromohexanes, acetylcysteine, carbocysteine, and ambroxol. Then in adjuvant we have the bronchodilators. Then we have the benzonatate and the carbetapentane in the antitussives. Then tincture of benzoin or menthol in the steam. Then we have in nebulizers, we have the benzocaine and the lignocaine. I have added this image to aid you guys. Then thanks for watching. I hope you enjoyed this video and subscribe my channel for more informative videos. Thank you.